So I think one of the ones I didn't get to was CAR Ts and sort of what my thoughts on CAR Ts are. So I was very excited about CAR Ts a little bit when I was much more convinced that getting to those B cells and the spinal fluid was going to be very important. I still think that they still probably have an important role, and it might be something that if we can do it once and get it passed, then I think they'll be much better maybe in the long term than sort of continuously beating those B cells over and over and over. But as I think I highlighted, one of the things that's important to recognize is that you need to do the experiments to kind of make sure that they work and for how long do they work. We don't want those B cells to be depleted for forever, right? We know that that can run into issues with infections and other things like this. And so trying to find a way where we can balance how long do we hammer them down, but still allow for antibodies to be made and things like this becomes really important. And so there's a lot of, when we talk about some of the CAR Ts as to kind of how they're made, what do they attack, normally we've been talking about CAR Ts against CD19, which is almost like the same marker as CD20. It works a little bit earlier and a little bit later in the cell line, so it gets a few more cells, I would say, than a CD20 does. But there's CAR Ts that have like a kill switch where you can, if they get a little bit crazy, you can sort of kill the drug. There's CAR Ts that not only go after those B cells, but can go after plasma cells that actually make antibodies. So is that going to be better than just the B cell depletion? These are all at the phase 1 study, so I think it's important to kind of keep that in mind a little bit, that this is going to be a little bit of a while. We're going to have to sort it out. But I think there's going to be a lot of cool stuff coming out about them. And so I'm excited to kind of see what the extra advantages of some of these CAR Ts are.
Yeah, I do these. I got some questions about perimenopause and then pregnancy, which I might just answer really quick. If you would like more information, I think I've done a webinar about pregnancy and family planning that's on the Rocky Mountain MS Center website, and I think one about menopause too. So thinking about perimenopause and the impact it has on MS, there's a lot of older studies that demonstrates that patients with MS that undergo perimenopause and menopause have a significant increase in disability levels following completion of menopause. I would say a lot of those studies are a little outdated, to be frank, at this point. And a lot of those are people that weren't on good therapies or were on therapies that I would consider suboptimal or not on any therapies at all. And so the data that we know about that transition of increased disability after menopause, I'm not 100% sure that's still true in today's modern DMT era, disease-modifying therapy era. We do see quite an overlap of symptoms between perimenopause and menopause and MS. So kind of like what I was going through in my talk about amplifying symptoms caused by MS. Most women that have gone through perimenopause or menopause will say, I've got brain fogginess, which check for MS, right? I've got fatigue, check for MS. I have trouble sleeping. We also see that in MS. And so sometimes those can amplify each other. I'm thinking about hormone replacement therapy, which is a whole talk we could get into on its own. There's no data that demonstrates hormone replacement therapy is harmful in MS patients, and that's whether it's like a vaginal estrogen cream or patches or pills. The only one that doesn't have good data is vaginal pellets, which actually the American College of OB-GYN recommends against just because of risks associated with those. But there is some data that maybe hormone replacement therapy can help slow down the atrophy or kind of shrinkage of tissue that we see in the brain. So there might be some data there that I think is beneficial actually from our MS patient standpoint. The other thing I would bring up too is there's other medicines, like there was one approved about a year ago called Veozah. That's a medicine that's not hormonally based, intended to treat hot flashes. And so we know sometimes as our patients get warm, it can worsen things like brain fog or numbness, tingling, or weakness and other things. So sometimes even treating the hot flashes can help with the treatment of those symptoms in MS. And I might just go on one other tangent because I know there was another question in here. Someone was asking about cooling mechanisms. So kind of thinking about this idea, I'm sure most of you have heard of, called Uthoff's phenomenon. which is this idea of as body temperature increases, it causes this recurrence of my MS symptoms. And we know there's some data that shows that an increase in core body temperature by as little as a quarter of a degree can cause recurrence of these symptoms. So thinking about whether it's hot outside, you're taking a hot shower, you're in a hot tub, or if you're stressed or exercising, there's a whole bunch of things that can increase body temperature. But know that we sometimes can see that causing recurrence of old neurologic symptoms, not because it's worsening inflammation, but just a little reminder that the pathway there for that nerve is not working optimally. So things that really help is trying to stay proactive rather than reactive. So trying to stay cool before you get hot and trying to cool yourself off. So cooling towels, I think, work really well. They're easy to take with you. So kind of putting them in water and then putting them in a plastic bag after you drain out the water. Those towels usually stay cool for some amount of hours depending on the brand. Fans with misters can be really helpful because you're increasing body, essentially emulating sweating when you mist yourself and then fan yourself off. Things that I think also work really well is just having a shirt in the freezer, throwing that on if you're about to go exercise. All of those I think are really important mechanisms. And then just thinking about how do I do things that are, I don't want to say smart, but kind of smart. Like I'm not hiking in the middle of the day, right? I'm going early in the morning before the sun comes up.
Cool. Just a couple of quick ones. So, what is a functional MRI? So, we didn't talk about this. Functional MRIs look at how uh, look at pathways. So it looks like if you try and think about certain activities, what parts of the brain are activated when you're doing that stuff. They're being looked at in MS because if it's affected by MS, that pathway may not work quite as well. But I would say it's still very much a research thing and not necessarily sort of something that we're doing. They're kind of hard MRIs to do. The question around there was a couple of questions around optic nerve and sort of now that optic nerve is part of this, is this something you should look at? With the new diagnostic criteria, there were actually like 5 papers that are planned to come out. One is very specifically around optic nerve. Although we can look at the optic nerve with MRI, there's probably better ways to look at the optic nerve that doesn't involve an MRI. So some of the eye colleagues can kind of do some of those tests better than we can. Some of that technology is now stuff that we don't do very much. So we talked about in that trial, for example, that looked at visually evoked potentials. Shocker, we don't have a visually evoked potentials machine at the University of Colorado because it's really hard to do. The room has to be at a specific temperature. You have to control the amount of light in that room. So fluorescent lights kind of decay over time, things like this. So it's easier to measure in other ways. And so I would say we're sometimes looking at it from a diagnostic perspective. So I think now with it being integrated a little bit more so, although we were doing a fair amount of this already, was, hey, I'm kind of borderline. It's not a slam dunk MS case. Let's order an OCT. Optometrists, some of them will have some of these machines. It's basically just a picture of the back of the eye and things like that. So we do them in certain circumstances. Again, these new criteria added a lot of things. And so we can't do everything at every time because you could literally probably spend your career getting tested for things if you start throwing in cognitive testing and things like this, and then you would really not like us. So we have to kind of limit some of those things. And I think trying to find that balance is what we're trying to kind of do with all of that.
Yeah, and I think the other thing I would add to that is maybe when we kind of think about where do we get clinically silent lesions, they often tend to be in the brain as opposed to the optic nerve, which you can imagine. I mean, I don't know what the size of the optic nerve is relative to my pinky,
Tiny.
but it's small, right? And so if you think about if I have even a small lesion in my optic nerve, it's a lot more likely to cause symptoms, including blurry vision or pain with eye movements or inability to see that color red quite as vibrantly. So I'm more likely to have symptoms if I have a lesion in my optic nerve as opposed to like a lesion in my brain. So it tends to be also one of those things that we can distinguish clinically, I feel like more too.
And we're going to miss something. Great. I mean, I think spinal cord, optic nerve, there's maybe a 50-50 chance that you would have symptoms if there's a lesion there. Um, but it's much less than the 90 or 95% of lesions in the brain that don't give you symptoms. And so that's why there's this push to really do a lot of MRIs, because we could otherwise miss a lot of stuff there.
Um, I will go on to some of these questions that I've got here. Does having MS increase the likelihood of having vascular disease? The answer to that is no. Although I will say, because there's a caveat to everything, if you are less mobile from your MS and you've got a genetic predisposition to high blood pressure, high sugars, whatever it may be, then maybe being less mobile might be one of those things where you go, okay, so then I can make an association between having MS and getting diabetes or something like that. There's also a couple questions about thyroid. There are some MS medications that do affect the thyroid, none of which we, I think, use very often here for other reasons. But MS by itself should not increase the risk of thyroid disorders. MS, we can see an association with other autoimmune conditions in general. We think about there may be some genetic component to MS, which I think is a whole separate conversation. But if your immune system cells are affected, it could increase the risk of autoimmunity. The most common autoimmune conditions we tend to see with MS is actually psoriasis, tends to be one of the most common. So yes, it can increase your risk of other autoimmune conditions, but not necessarily all of them. The other question I might add in this little bundle is this risk of osteoporosis. Is there an association between that and MS? And so not necessarily directly, although we know if you're using your muscles and bones less, like you're doing less weight-bearing exercises, you can have an increased risk of osteoporosis as you age. So that's one component to kind of think about is, are we having less weight bearing that we're doing, depending on what levels of disability look like. The other thing too, and one of the reasons we don't necessarily advocate for supratherapeutic vitamin D levels or vitamin D levels that are really high, is because there's some studies that show that having vitamin D levels that are too high can actually leach calcium from your bones. So that's why we try to aim for vitamin D levels in the normal range. And so that's one way that I could say, hey, there's an association there that we could make, but not necessarily, I have MS, I'm gonna get osteoporosis or osteopenia.
Give me these there. There's a couple more questions on remyelination, so I think that was the latest trial that I could kind of show for it. I think one of the comments I would make around remyelination is there's an idea now that some of these drugs may not be working because you then also need to stimulate the pathway that you're trying to affect. So if you stimulate the pathway and then hit it with some drugs that might activate remyelination or things like this, that might help improve things a little bit. No guarantees, but that's at least kind of where some of these other things go. And I think it helps tie in a little bit with sort of this issue of how do you maintain function, how do you prevent progression and all these other things. And like Dr. Shah brought up, this concept of exercise and things like this. If you look at the weight-based dosing studies, right, if it's not a dosing issue and it's, hey, smaller people are doing better, the point to make is that being a good weight, getting that activity that's doing there probably are the things that are going to help you the most. And so this wellness concept, this of exercise is what we're kind of left with, right? And so if we're going to stress something around this, it's trying to stay as active as possible, mentally, physically, and everything else to try and kind of help with those things. The other thing I would talk a little bit about is smoldering. So smoldering, when you ask a lot of the MS docs, we get the chills, mostly because I think it's trying to get at a concept around progression, which we can all kind of get behind, but it implies that progression, that there's only one thing that leads to smoldering progression or smoldering, disease activity or things like this. And I would say I would be a little bit cautious to that, right? I think that the components that add to progression are probably a lot of different things. The microglia component, this issue of pearls, we know is important. But now we're starting to get this idea of maybe it's important earlier in the disease activity. If the pearls are starting to develop at the same time as you have an enhancing lesion or kind of very early on for that lesion, do we want to use them later as a progressive drug, or do we want them to use earlier when it's can help, when you probably maybe have more pearls? We don't really have great data as to like who has more pearls, older people or younger people, and this idea that maybe we would use these drugs in patients who are still progressing and have been on a CD20 for many years. They may not have any pearls. So trying to use these drugs in that situation may not be helpful. Um, so I think that we're still kind of needing some information to kind of understand what smoldering means. Smoldering is probably some deconditioning. It's probably a little bit of aging. It's probably a degeneration component. If you have a cell that's maybe not dead yet, but it's kind of getting close, and it's really having to work hard to kind of get its signaling through, there's probably going to be reactive oxygen species that are going to be ready to knock it off, as it tries to ramp up, right? And all that is separate from sort of the smoldering piece and trying to understand that a little bit. So I think smoldering is kind of a nice umbrella term. I think it helps paint a picture of something for progression, but it's probably many different things that are kind of contributing to kind of give a smoldering picture, a progressive picture to things.
Yeah, and I might add on to that too. I think there was a question about how do I know what's progression? How do I know what's worsening with age? And I think both of us would probably say if you figure that out, let us know, because it's really, really hard to figure out, right? So if we kind of think about for all of us, if we said we, again, lived in the nice little silo or the nice little bubble, if we said we take the same exact stimulus and we expose it to us every decade of life, it would feel very different as we age. And the easiest example is saying, well, when I was 20 and I pulled an all-nighter, it was not that big of a deal, right? When I was 30, like, okay, maybe a little bit harder. When you're 40, all right, maybe I need more than a cup of coffee to help me get past it. And when I hit 60, gosh, an all-nighter, I'm gonna be down for days, right? And so you kind of think about that, and that's in the context of just saying that's aging, right? And we know that our bodies react different to the same stimuli with aging. And then you throw MS in there, and you throw a decaying brain, which all of our brains start to decay once we hit 30, which is fun. And so you kind of say, well, if I throw all of these different factors into it, plus I'm probably getting diagnosed with other medical conditions as I age, right? That's a common thing that we see, MS or not MS. And then I'm also becoming less active and all of this. It all amplifies or builds on top of one another. And so kind of going back to this idea of saying socially well, physically well, and emotionally and cognitively well becomes really important. And it's one of those things where we like to say being as proactive as possible is important. One of the other questions I had in here is, well, how do I stay active if I can't move? And the answer is there's a lot of things you can do, even if you go, these legs aren't doing exactly what I want them to do. So water therapy, I already harped on that one. The other things too is there is chair Pilates, which you don't need to be up and mobile to do, right? Can you, if you say, hey, I don't have great hand function or hand strength function, get one of those grip strength machines? And can I do that when commercial breaks pop up while I'm watching TV? Sure as heck can, right? There's things that I think everyone can do regardless of disability levels that maybe might not look like traditional exercise where you go, I get on the elliptical for 30 minutes. But I think it's saying, and this is a really great discussion to have with your doctors or your therapists, about what can I do with my current limitations that allows me to still exercise. I think there's the other things that I might throw out there too is saying, well, if there's symptoms that are limiting my capacity to exercise, is it that I'm getting really overheated and it's making my MS symptoms worse? So maybe I do the water therapy because then I'm cooler. Or is it that I don't have great balance, so I can't bike? So maybe I think about a recumbent bike where I don't have to worry about balance. I think it's thinking about what adaptations can I make? And if you ever need ideas, I've got a ton of them. Yeah.
Lots of questions then on other things, lifestyle stuff too as well. So why aren't vitamins and other natural medicines promoted as much as pharma meds when suggesting healthier lifestyles? Uh, Easier, they don't pay us as much. No, just kidding. The I think it's because we've been burned a lot in this area, right? So if you look at the data that's required to get a pharma drug out there, right? When we're talking about, sort of a billion-dollar proposition to get a drug approved, that's not happening with vitamins. And when we start to kind of, hey, this vitamin, this product looks promising, it becomes, something that can sometimes develop legs really quickly. I'll bring up the example of biotin. So for people that don't remember, biotin is a vitamin, um, great for hair and nail growth and things like this. And in doses that were super high. So sometimes when we're talking about hair and nail stuff, it's like a 1 milligram a day. They were talking 300 milligrams a day doses. Interfered, for example, with some of the lab testing because biotin is used in some of that testing. But and initially, the small trials looked very promising, but what we ended up finding out is that it didn't work. So when they did the big phase 3 trials, it didn't seem to have really any effect at all on progressive disease. Vitamin D can kind of could develop legs. We encourage it. There was actually a trial recently out of France that showed a 30% reduction in relapses with vitamin D. When you have a 50 or 80% reduction with the other drugs, I'm not going to recommend vitamin D by itself, compared to a drug that I think is going to work much better. We talk about it because we think it's a good adjunct and good for bone health and a lot of other things. And it's a vitamin that you don't tend to get through foods. And so we push it that way. But that's why we don't sometimes bring these up too much because we hardly ever have that degree of scientific evidence. Alpha lipoic acid was a trial that actually got stopped early and then restarted, but there were some liver issues associated with alpha lipoic acid, which is a common over-the-counter type product that you can kind of look at as well. And so, we've been in the MS field. I think a lot of things kind of come maybe once a year, every couple of years, and we just need to be a little bit cautious about sort of recommending some of these products until we have enough data to really kind of recommend them. Vitamin D is one, and that's why we push it compared to some of the other ones. Had a couple questions on the PONS device. This is something that, as I understand it, I've not seen it or had a patient actually try it, that stimulates your tongue with the idea that it could cause remyelination, stimulating the vagal nerve.
I've had a couple.
You've had a couple
A couple of patients that have tried it. I think the reactions that I've heard have been 50-50.
Yeah.
I've had one, I think, that said that worked really well. I had another couple that said, I'm not sure what I spent my money on.
Yeah.
So it's
Yeah, the vagal nerve stimulator has been something that has recently been approved, and actually that's like an implantable device for rheumatoid arthritis. There is a trial there's a group here trying to look at vagal nerve stimulator by stimulating sort of the earlobe that provides a current through that stuff. Bennett with Kristen Welly in neurosurgery. And so I think there's a lot of things kind of coming up with those devices to kind of check them out. Again, they're very early on, and so from an MS perspective, a little bit tougher. The Sionic sleeve, for people that don't know, is something that we do talk a lot to our patients about. Somebody brought up the next generation. I'm actually not familiar with the next generation one, so more to come maybe at the next one for that. But assistive devices are something that, we've used AFOs, walkers, wheelchairs, all these different things as they come up with, I think, newer things. Stand-up walkers are something that I've talked to a lot of patients about. Thankfully, we don't need to have quite as many of those conversations as we did in the past because we're able to kind of slow that progression and the amount of damage to get there before. But I think there's just a lot of stuff that's still out there, and I think it's important to kind of bring those up. And again, these devices don't require as much data, so a lot of times they get popped up without us knowing about them. And so you tell us sometimes, how I learned about the psionic sleeve was a patient came in and told me about it. And I was like, hey, that's pretty cool. That sounds pretty good. And now we can do some test trials in the fourth floor for that. And so, this is as much as I see it, kind of a give and take sometimes for it. So
I think we're at time.
at
I
time,
got the tea from Kelsey.
done,
Yeah.
cut off. All right.